Okay, good morning everybody. I'm Dr. Keerti Wali presenting you to how to read the pentagram today. As you know, normal cornea is a prolate ellipsoid, which means the curvature is higher in the center as we go to the periphery. I'm sorry, the timer is showing 8 minutes, but I was allotted.
Sorry. I'll check with the AV team. There is some technical glitches. You're allotted 15 minutes. You will get the 15 minutes. Don't worry. Please go ahead.
Okay, thank you. Okay, so as we go from the apex to the limbus, the curvature flattens. Pentagram is a modern corneal tomogram which uses the Schleifer camera principle to take the anti-assignment images and gives us the corneal tomography, which is a 4-map display. When we see this report, it shows us the corneal parameters on the right hand side and the 4-map composite map on our right hand side and corneal parameters on our left side. So the first thing we have to see is the QS, that's a quality specification, which has to be okay. And below that, a Q value of the cornea showing the asphericity of the cornea is shown, which is measured over the 8 mm zone. And the first zone in this shows us the K1, K2, and the mean K, Km. This is important to plan the refractive surgeries because in myopic patients, one diopter correction flattens the cornea by 0.8 diopters, and in hyperopic, one diopter steepens by 1.2 diopters. So the post-refractive surgery keratometry has to be more than 34 and less than 49. So that is why this is important. And Km is important because there is a high risk of free flap if the Km is less than 40 diopters and a high risk of button holing if the Km is more than 46 diopters. And in the third section here, we can see the Kmax, maximum keratometry values. This has to be less than 49 diopters. The normal difference between two eyes is less than 2 diopters. And the Kmax and the K2 difference has to be less than 1 diopters. If the difference is more than 1 diopters, then for all the calculations, we have to use Kmax instead of K2. Okay, so in the first section, we also see a topographic astigmatism, and we have to correlate with the manifest astigmatism. If the manifest astigmatism is more than this topographic astigmatism, it indicates there is a lenticular astigmatism, and patient should be told that this astigmatism is going to be remaining even after the refractive surgeries. Okay, the second section shows the similar parameters for the back surface of the cornea, and the third parameter shows the pupil center, the pupil apex, and the thinnest location with their X and Y coordinates. Cornea is referred to be thin cornea if it is less than 470 microns. So any patient shows us the report, even though it is a normal tomography and the corneal thickness is less than 470, then it's not a good candidate for keratorefractive procedures. And if it is less than 500 microns with abnormal topography, then also it's a high risk case. If the both eye difference is more than 30 microns, it's suspicious of ectatic disease. And if the difference between the pachy-apex and the thinnest location is more than 30 microns, is also suspicious. And we have to see this Y coordinate of the thinnest location. Here it is minus 0.21. If it is more than 0.5, it is suspicious. And if it is more than 1, it is definitely a high risk character. The last section here shows the AC parameters, which is important for planning the phakic IOLs. Coming to the corneal maps, it includes the anterior sagittal map, the anterior elevation map, the posterior elevation map, followed by the pachymetry map. The anterior sagittal map shows the steep areas in the hot colors and the flat areas on the cold colors. We have to see 2 points in the 5 mm zone, which is clinically significant. And if the inferior is steeper by 1.5 diopters than the superior, it is significant, and if the superior is steeper by more than 2.5 diopters, that is a significant value and it indicates the high risk. A normal pattern is a symmetric bow tie as seen on this picture. So any of these features shown in the table, with the thinnest location less than 470, TLY coordinate more than -1, if there's a skewing of radial axis more than 22 degrees, if there's a butterfly claw or a D-shaped pattern on the sagittal curvature, if there's a symmetric pattern but more than the steeper than 50 diopters is also a high risk. So some of the sagittal curvature maps we'll see here. This is a round pattern with the apical keratometry range in the range of 50 diopters. This is a high risk feature. This is a superior steep pattern with a superior inferior asymmetry, a high risk feature. This is an inferior steep pattern with the keratometric values in the higher range and inferior asymmetry more than 1.5 diopters. This is a high risk characteristic. This is an irregular pattern, definitely a high risk. This shows a symmetric bow tie with skewing of the radial axis. This comes in the moderate risk. Asymmetric bow tie with inferior steepening is a high risk if associated with keratometry values more than 50. However, this comes in the moderate risk because the keratometric values are not so much. Okay. This shows the asymmetric bow tie with superior steepening. This shows the asymmetric bow tie with skewing of the radial axis, characteristic of keratoconus. This is a butterfly pattern, characteristic of PMD. This is a claw pattern, characteristic of inferior corneal ectasias. And the next map is the elevation map. Elevation maps takes a reference body and gives anything above that point in the cornea as anterior in the plus point and below that as posterior negative points. So we can use multiple type of reference bodies. The most commonly used are the best fit sphere and the best fit toric ellipsoid. BFS is important for localizing of the cone, and BFT is important for seeing the height of the cone. So a normal shape on the BFS float mode is the regular astigmatism, which is symmetric hourglass pattern. Okay, some abnormal shapes include a skewed hourglass, a tongue-like extension, okay, and an isolated island in the center. And elevation maps are considered to be high risk if on the best fit sphere float mode in myopic patient, the anterior points are more than 8 and the posterior points, elevation points are more than 18 microns. And in hyperopic, if the anterior is more than 7 microns and posteriorly more than 28 microns. The same thing if it's a best fit toric ellipsoid float mode, the values change. And if the anteriorly, if it is more than 12 microns and posteriorly more than 15 microns, it is high risk. So here you can see both the reference bodies in same patient. As you can see on the left side is the best fit sphere showing the localizing the cone, and in the right side is the best fit toric ellipsoid which is showing the elevation, the height of the cone. Okay, so BFS is important for cone localization. Right. So coming to the next map, the pachymetric map, it shows the distribution of the corneal thickness throughout the entire corneal diameter, the normal shape being the concentric, and in 5 mm zone you have to see the inferior and superior thickness at the 5 mm level. The difference should be less than 30 microns. As in this case, it's 534 and 530. The difference is hardly 4 microns. It is not significant. If it is more than 30 microns, it is significant and high risk. Okay, so in this we have to localize the thinnest location on x and y coordinates, and if it is on x coordinate, if it is displaced, it is called a horizontal displacement of thin location. This is abnormal, and the vertically displaced thinnest location is also abnormal. This is a bell-shaped pattern seen in pellucid marginal degeneration. Generalized thinning till the limbus is seen in keratoglobus. Okay. Berlin ambrosia enhanced ectasia display is a special feature that we get with Pentagram. In this, the Pentagram gives us the elevation maps using the enhanced BFS. This uses the concept of exclusion zone. A 4 mm zone of ectatic cornea is excluded and the elevation maps are given along with this enhanced BFS. So this is how the map looks like. It has got so many components, the maps on the left side and the corneal thickness graphs on the right side. Okay. The first zone in this shows the two elevation map, the front surface and the back surface using the standard best fit sphere. And the second zone, you can see it has given the there is anterior exclusion map and the posterior exclusion map. The third zone has got only 3 colors, green, yellow and red. This gives the difference between the two of them, the superior one and the inferior one, the regular BFS and the enhanced BFS difference. Okay. So the third zone gives us 3 colors, green meaning it's normal, yellow is in the borderline difference, and red showing that it's a pathological change, that magnitude that we typically see in keratoconus patients. Okay, so in this case, you can see that the difference is very significant, and this is made clear cut in the third zone. It is shown by red color. So this is how the Berlin ambrosia enhanced ectasia display helps us identify early keratoconus patients. And this also has 2 graphs, which is a corneal thickness spatial profile and the percentage thickness increase profile. Okay, so in this, what we have to see is 3 points. One is the curve, the red line where it is lying. It has to be lying within 95% confidence interval limits in both the graphs, and the average progression index. The normal values are 0.8 to 1.2. Okay, anything less than 0.8 and more than 1.2 is pathological. Okay, and another thing we have to see is at 6 mm zone where this red line is falling. That is an important thing. This is a normal shape which is lying within the 95% confidence interval and the average of 0.9. Okay, this is an abnormal shape wherein the slope is very quick. It is falling very quickly before even reaching the 6 mm zone. Okay, and here you can see the average is 2.3. This is characteristic of corneal ectasias. This abnormal zone is showing the S shape, and S is happening before reaching the 6 mm. If this S is after 6 mm, it will show a moderate risk, not a high risk. This graph is showing a high risk case with an average of 2.4. Okay, this is a flat shape. This is also abnormal, and this kind of shape is seen in corneal edema secondary to any cause. And the average here will be very low, 0.6, less than 0.8. Okay, this is another abnormal shape which is showing an inverted shape. This is inverted upwards, and the average is in minus. This kind of graph we see in pellucid marginal degeneration. So as I told you, a S-shaped curve after the point of 6 mm is a moderate risk. This has to be monitored, and here you can see the average is pretty normal, 0.8. Okay, the next thing we all see is the keratoconus indices. They are given differently in different machines. And the most important indices among them are the index of surface variance, ISV, index of vertical asymmetry, IVA, and the aberration coefficient, ABR. Okay, we don't have to remember these values because the abnormal values are shown in the report in yellow color and pathological values are marked by red color. So the colors itself will alarm us. Okay, so this is how the Pentagram report shows us the indices. And in this report, you can clearly see they are marked by red. So you don't have to remember those values, but the color coding itself will give us a red flag sign in your mind. So when we are deciding for a keratorefractive procedure, even if there is one high risk or two moderate risk, it's not a good case for keratorefractive procedures. Can consider the lenticular procedures. Or if there is one moderate risk, we can do a PRK, no flap-based procedures. If there are no risks, then we can decide on the PRK or LASIK depending on many other things. Okay, let's go through some of the Pentagram maps now and how to read them. In this map, you can see that the anti-sagittal map is showing a symmetric bow tie, and the elevation and the posterior, both the elevation anterior and posterior do not have any higher values than +8 or +18, and the curvatural map is showing a concentric ring pattern, which is normal. And you can see the keratometric values are 41 and 44, which shows the astigmatism of 2.8. The thinnest location is 529 microns, which is within the normal range. Okay, so this is a normal cornea showing a with the rule astigmatism. However, this QS factor here, this is indicating that this scan needs to be repeated. Fixation losses were there while the study. Pentagram hardly takes 2 seconds to capture this, so it can be repeated. It has to be repeated. If the eye closes or fixation is lost during that time, the QS will be shown like this. Okay, this map is showing a horizontal symmetric bow tie with no significant parameters on the elevation map, both anterior and posterior, and thickness map is also concentric. The thinnest location is 506 and X and Y coordinates less than 0.5. Okay, and everything else is normal, hence it's a simple against the rule astigmatism. This case, you can see that there is a asymmetric bow tie with skewing of the radial axis. Okay, and here you can see some values like +12 and posteriorly +27, +19 in the center on the posterior map. So on the elevation, this is a best fit sphere, BFS, not BFT. On best fit sphere, if it is more than +8 anteriorly, more than +18 posteriorly myopic, it is significant. It is pathological. And here you can see the thinnest location has shifted. It's not in the center. You can see the thinnest location is 598 microns at +1.05 and -0.63. -163 on Y coordinate is definitely suspicious, and on X coordinate is definitely a horizontal displacement +1.05. Okay, but the thinnest location is 598 microns. So if this patient comes to us for a refractive procedure, then we have to advise for a serial follow-up. And if it is stable over even 1 year, then we can take them up for a surgery, not otherwise. Otherwise, if there is a progression, then it has to be treated accordingly. This map Hello?
Yes, doctor, continue. We can hear you.
Okay, sir. So this map is showing us, when we see on this map, suddenly at the corneal thickness map, we can see the thickness is 434 and it's in red color. So hot colors. So suddenly we'll feel like, okay, maybe it's a ectatic cornea. But then when we see the elevation map, there are some points +14, +19, which are in the pathological range. But in the posterior, this is not coinciding. Like here it's +4, +5. It's very less. Okay, so this is not coinciding with these values, a suspicion of ectasia. And when we see on the curvature map, it's pretty flat case. Okay, so when such kind of a picture is seen, this kind of flat case are seen post myopia, post myopic LASIK. Okay, when a patient undergoes myopic LASIK, the center becomes flat and this kind of the curvature is seen. And you can see residual astigmatism of -1, vacuum, and the thinnest location is 433. Okay, so this thinning is because of the LASIK, not because of the ectasia. So this is a pentagram showing post myopic LASIK, a normal cornea. Okay, so this is a picture showing post hyperopic LASIK, wherein it looks like the keratometric values looks pretty normal. Center steep and the periphery is flat. Okay. However, the point indicating the hyperopic LASIK here is, if you see the thinnest location, which is 492 microns, this is decentered totally on both X and Y axis. Okay. So this is an indication that this patient has undergone a hyperopic LASIK. This is a very straightforward map of advanced keratoconus that anyone can understand. The keratometric values are pretty high, 68.3 and 75 diopters, and with a hotspot on a curvatural map. And the elevation points are at +97, +65, very high. And the posteriorly it is +169, very high values. And the thinnest location is 359 microns. But the X and Y coordinates are normal here. So this shows a central advanced cone. Okay, so this is an advanced keratoconus. But our confusion always lies with cases like this. If this patient comes to us for refractive surgery evaluation, when we see these curvatures, it could be simple astigmatism, 44 and 47.1, and we get the pentagram done for them, and we see a asymmetric bow tie with superior steepening, which is not significant. The difference is not more than 2.5 diopters here. If you see 46 and 44 and 43.4. Okay, so this is not significant. And on the elevation maps, there are no significant points. On the posterior elevation maps also, there are -24 is one point, and +15 just borderline, but +18 is the pathological, more than +18. And the thickness is also normal. The thinnest location is 528 and it is not decentered. Okay, so in these cases, there is a lot of confusion about what to do. And in these cases, Berlin ambrosia curve and the indices will help us to see for the risk. Here in Berlin ambrosia curve, you can see that after 6 mm zone, there
Dr.
is a
Keerti?
Yes.
Dr. Keerti, can you please try and sum it up now?
Sorry?
Can you make it a little faster?
Yeah, sure. Yeah. I cannot go to my screen.
Okay, can you please start sharing your screen again? And you're 2 minutes late in your section, so I would request you to please sum it up in next 1 minute.
Yes, sir, I am done in another 2-3 minutes. So here you can see the average is very high, and when we see the topography of the other eye, this shows a clear-cut keratoconus with steep K values and the typical features, and the thinnest location is 502 microns. And on the Berlin ambrosia curve, it indicates keratoconus, and the indices are all in the pathological range. So this case definitely needs treatment for keratoconus rather than a refractive procedure. And this is the last map, which shows the keratoconus like picture. When we see on the sagittal curvature, we see a hotspot decentered inferiorly, and the thinnest location is decentered horizontally, and it is 489 microns. Okay, but one thing we see here is the superior keratometric values are very flat, 37.3, 39.8, and all that. So this is an indication that it is a post LASIK case rather than a simple regular corneal ectasia case. Okay, so this is indication of post-LASIK ectasia. On Berlin embrasio also you can see that the indices are pathological and there is a S shape and the steep fall in the percentage corneal thickness. Okay, so these are all the this is how Pentagram helps us in knowing the high risk and the moderate risk patients for the refractive surgery. Some non-topographic applications are in contact lens fitting, for the scleral lens fitting, for the corneal optical densitometry, for the cataract analysis, for IOL calculations, especially in post-refractive cases. We get a holiday report that gives us a EKR 65 flattened case. Okay, thank you so much.